Surgeons have a term they don't always say out loud. They call it the silent complication, and it's not what most people expect. It's not infection. It's not bleeding. It's not a failed stitch or a visible surgical error. It is something far more invisible, and in many cases, far more life-altering. It is what happens to the brain after anesthesia. And if you or someone you love is over the age of 70, what you're about to hear may completely change how you think about surgery forever. Because there is a question almost no patient thinks to ask, and most doctors never bring it up unless they're forced to. But that question can influence something far more important than the surgery itself. It can influence how your mind wakes up afterward. Stay with this carefully, because this is where most people are completely unprepared. When someone is told they need surgery, their focus instantly narrows. They think about the surgeon's reputation. They look at success rates. They ask about recovery time, pain levels, and how long until they can walk again, eat normally, or return home. And all of that feels logical. It's what any reasonable person would worry about. But over years of working in anesthesiology, one pattern becomes impossible to ignore. For older adults, especially those above 70, the biggest risk is not always the surgery itself. It is what happens during the hours when they are not conscious at all. General anesthesia. The state where the body is fully shut down, breathing is taken over by machines, and the brain is pushed into a chemically controlled sleep so deep that awareness disappears completely. For a younger patient, the brain usually rebounds quickly. They wake up, recover, and within days, feel like themselves again. But in older adults, something very different can happen. Because aging changes more than appearance or strength. It changes something called cognitive reserve. Think of it as the brain's buffer zone, its ability to absorb stress, chemical disruption, and surgical shock, and still return smoothly to normal. In younger brains, that buffer is strong. In older brains, that buffer becomes thinner, more fragile, less forgiving. And when general anesthesia is introduced, multiple powerful drugs act on the brain at once. These medications don't gently put you to sleep. They suppress communication between brain cells across multiple regions, responsible for memory, awareness, and attention. Now add another layer. In older patients, the liver and kidneys process these drugs more slowly. That means the chemicals stay in the system longer than intended. The brain remains under suppression longer than expected, and recovery becomes less predictable. This is where things begin to shift. Because in a significant number of elderly patients, something appears within the first few days after surgery. Not pain, not infection, but confusion, disorientation, a sudden change in awareness that families are never prepared for. This is called postoperative delirium, and once you see it, you don't forget it. Patients may wake up not knowing where they are. They may believe they are in a different time, sometimes decades in the past. They may fail to recognize family members standing right in front of them. Some become restless, agitated, even frightened. Others go quiet, withdrawn, almost unreachable. To the family, it feels like the person they knew has temporarily disappeared. And while doctors may describe it as temporary confusion, the emotional impact tells a different story. Because this is often the moment families realize something has fundamentally changed. And what makes this even more concerning is what can follow next. Delirium is not always the end of the story. What most families don't realize is that postoperative delirium is often just the beginning of a deeper story. Because in a significant number of older patients, the confusion that appears after surgery doesn't always vanish completely. It fades, but it can leave something behind. Something subtle at first. Something families sometimes mistake for normal aging. This is where we enter a condition known in clinical settings as postoperative cognitive dysfunction, often shortened to POCD. And unlike delirium, which is usually obvious and dramatic, POCD is quiet. It doesn't announce itself with confusion or hallucinations. Instead, it shows up in smaller, slower changes. A missed appointment here, a forgotten conversation there, a hesitation where there used to be quick thinking, a familiar word that suddenly takes longer to recall. At first, it may not look serious. Family members might say things like, "He's just recovering," or "She's a bit slower after surgery." But over time, the pattern becomes harder to ignore, because what is changing is not just memory and isolation. It is overall mental sharpness, processing speed, mental clarity, the ability to multitask, to follow conversations smoothly, to stay mentally sharp in everyday life. And for some patients, this change can last weeks. For others, months. And in a portion of cases that researchers are still actively studying, the recovery is incomplete. Now imagine what that means in real life. This is a person who was fully independent before surgery, driving, managing finances, cooking, making decisions without hesitation. Then slowly, after what was supposed to be a routine procedure, something shifts. Not dramatically at first, but enough that family members start noticing small gaps. Bills get forgotten. Words take longer to come. Directions become confusing in familiar places. And what was once a confident, independent person begins to require subtle support, sometimes without even realizing it themselves. This is why POCD is so concerning in the medical community, because it does not just affect test results or memory scores. It affects independence, identity, daily life. And while research is still ongoing about the exact cause, one thing is clear from decades of clinical observation. Older adults are more vulnerable. Their brains recover differently after deep pharmacological suppression, and the transition back to baseline is not always complete. Now, to be precise and honest, the scientific debate is still open. Some researchers believe anesthesia may directly contribute to these changes. Others suggest it may accelerate underlying neurological decline that was already beginning silently. But regardless of the mechanism, the clinical pattern has been repeatedly observed. And that is what matters most in real-world practice. Because in anesthesia, we don't just measure what is theoretically possible. We measure what consistently happens in patients. And one of the most important consistent findings is this. There are differences in cognitive outcomes depending on the type of anesthesia used. In many cases involving older adults, regional anesthesia techniques show better cognitive recovery patterns compared to full general anesthesia. Lower rates of delirium, faster return to baseline function, shorter hospital stays, and fewer reports of long-term cognitive decline from families. This has been documented across multiple medical centers worldwide, which raises an important question. If alternatives exist that may reduce cognitive risk, why isn't everyone offered them by default? The answer is more complicated than most people expect. Because in modern surgery, there is something called standard protocol, a default pathway designed to work for the average patient. But here is the critical detail most patients never hear. The average patient includes a wide age range, and what works safely for a 3-5-year-old is not necessarily the same for a 7-5-year-old. Aging changes everything, from drug metabolism to brain sensitivity, meaning older patients are not just older versions of younger patients. They are physiologically different, and that difference matters deeply when it comes to anesthesia. Once you understand the risks, the next question becomes unavoidable. If general anesthesia carries higher cognitive risk in older adults, what are the alternatives? And more importantly, are they actually real options in modern surgery, or just theoretical ideas? The truth is this: in many cases, alternatives do exist. They are already being used in hospitals around the world, but they are not always discussed unless the patient specifically asks. And that is where everything changes. Because anesthesia is not a single approach. It is a toolkit, and choosing the right tool can dramatically influence how the brain responds after surgery. Let's go through the 4 most important alternatives used in modern medicine. The first is called peripheral nerve block. This is one of the most powerful techniques for surgeries involving the arms, legs, shoulders, knees, and hips. Here is how it works. Every sensation of pain in the body travels through specific nerve pathways before reaching the brain. Think of these nerves like electrical cables carrying signals upward. A peripheral nerve block works by interrupting that signal at the source. Using ultrasound imaging, the anesthesiologist precisely identifies the nerve bundle responsible for sensation in the surgical area. Then, a small amount of local anesthetic is injected directly around it. The result is targeted numbness in only the area being operated on, not the entire body, not the brain, just the surgical site. The patient remains awake or lightly sedated. There is no breathing tube, no full unconsciousness, no deep pharmacological shutdown of the brain, and importantly, recovery is often smoother because pain control continues even after surgery for many hours. This reduces the need for strong opioid medications, which themselves can contribute to confusion in older adults. Now move to the second technique, epidural anesthesia. This is commonly used for larger surgeries involving the chest, abdomen, or lower body. You may have heard of epidurals in childbirth, but the principle extends far beyond that. A very thin catheter is placed in the epidural space near the spinal cord. Through this catheter, local anesthetic is continuously delivered during the operation. This blocks pain signals from large regions of the body. The key advantage here is that the brain is spared from deep levels of anesthesia. Often, only minimal sedation is needed for comfort. This means less chemical suppression of brain activity. And after surgery, the same catheter can continue delivering pain relief for days. This reduces the need for systemic painkillers and helps patients regain mobility earlier. Now, the third technique is spinal anesthesia. This is commonly used for surgeries below the waist, hip replacements, knee surgery, bladder procedures, certain abdominal operations. In this method, a small injection is placed into the spinal fluid in the lower back. The medication spreads in a controlled way, creating numbness from the waist down. The patient remains conscious or lightly sedated. No breathing tube is required. No full unconsciousness is induced. And because the brain is not deeply suppressed, recovery is often clearer in older adults. In fact, in many hospitals worldwide, spinal anesthesia is now the preferred option for hip fracture surgery in elderly patients due to its association with reduced delirium risk. And finally, the fourth technique is conscious sedation combined with local anesthesia. This is used for smaller procedures like cataract surgery, minor hernia repairs, hand surgeries, and biopsies. In this approach, the patient receives mild sedative medication that creates a calm, relaxed, semi-awake state. They are not unconscious. They can respond if spoken to, but they are comfortable and anxiety-free. Meanwhile, local anesthetic is applied directly to the surgical site to eliminate pain. For many short procedures, this combination is more than enough. And importantly, it avoids the heavy cognitive load that comes with full general anesthesia. Now, here's what makes all of this significant. These are not experimental techniques. They are widely used, well-studied, and part of modern anesthetic practice. But their use depends heavily on the type of surgery, the patient's health condition, and critically, whether the discussion actually happens before the operation. Because in many cases, the default pathway is still general anesthesia, not because it is always necessary, but because it is familiar, efficient, and routine, which leads to the most important question of all. How do you, as a patient or family member, make sure these options are actually considered? At this point, the real issue is no longer about whether alternatives exist. They do. The real issue is whether they are ever discussed in time. Because in most surgical pathways, decisions about anesthesia are made quickly, often by default, and sometimes without the patient fully realizing that multiple options even exist. And that is where patients over 70 are at the highest risk of being left out of the conversation that matters most. Not intentionally, not because anyone is trying to hide information, but because modern surgical systems are built around efficiency, routine, and standard protocols. And standard protocols are designed for the average case, not the individual brain sitting in front of the doctor. So the most important tool a patient has is not medical knowledge alone. It is the ability to ask the right question at the right time. Let's make this very practical. When you are sitting in the preoperative consultation, the moment you are told about anesthesia, most people simply nod and accept what is offered. But there is a different way to approach it, a way that changes the entire tone of the conversation. Instead of passively accepting the default plan, the goal is to invite discussion. Here is the exact kind of question that opens that door. I have read that general anesthesia in patients over 70 can increase the risk of postoperative delirium and cognitive changes. Can we discuss whether a regional or alternative anesthesia technique is suitable for my procedure? This is important for one reason. It does not sound like fear. It sounds like awareness. And that changes how the medical team responds. It shifts the conversation from routine explanation to clinical evaluation. Now, if the response is positive, the team will begin discussing whether a nerve block, spinal, epidural, or sedation-based approach is appropriate. But sometimes, the answer will be that general anesthesia is still necessary. And that is where the second question becomes critical. Instead of accepting a vague reassurance, you ask, what specifically about my surgery requires general anesthesia instead of a regional option? This question forces clarity, because now the decision must be explained in clinical terms, not just routine habit. There may be very valid reasons. Certain complex surgeries truly require full anesthesia. Some procedures involve long durations, airway control, or surgical positioning that cannot be safely managed otherwise. In those cases, general anesthesia is not optional, it is necessary. But here is what is equally important. There are many cases where it is not strictly required, but still used out of habit, familiarity, or workflow efficiency. And that distinction matters more in older adults than almost any other group, because aging changes everything about anesthetic response. Drug clearance is slower, brain sensitivity is higher, recovery is less predictable, and cognitive reserve is reduced, which means even small differences in anesthetic depth can have meaningful effects afterward. Now, if at any point the response feels dismissive, something like, "This is just how we do it," without explanation, that is not the end of the conversation. It is the signal to go one step further, and that step is requesting direct input from the anesthesiologist. Because while surgeons focus on the procedure itself, anesthesiologists focus on something equally important: how the brain will respond during and after that procedure. A good anesthesiologist working with older patients will understand these concerns immediately. They think about delirium risk. They think about medication load. They think about emergence time the moment the brain wakes back up. And many of them are already actively adjusting techniques to reduce cognitive strain in elderly patients. But here is the key detail most people miss. They can only tailor the plan if they know the patient is concerned about it. If no one asks, the default plan often proceeds without deeper personalization. And that is how two patients with similar surgeries can end up with completely different recovery experiences. One returns home mentally sharp. The other struggles with confusion that was never anticipated. Now, to understand how powerful this difference can be, you have to look at what actually happens after surgery. Because the outcome is not only determined in the operating room, it continues into recovery. To understand the real impact of anesthesia choices, you don't need abstract theory. You need real patterns. Because in hospitals around the world, two patients can undergo almost identical surgeries and walk out with completely different mental outcomes. And the difference is not always the surgeon. It is often what happened before and during anesthesia. Let's start with a common scenario. Patient 1 is a 7-8-year-old man scheduled for knee replacement surgery. Before the operation, everything appears routine. He is independent, mentally sharp, active, still managing his own life without assistance. The surgery itself goes smoothly. Technically, perfect. No complications, no surgical errors, no visible problems. He receives standard general anesthesia, the procedure is completed, and he wakes up as expected. On paper, everything is a success. But in the days that follow, something subtle begins to change. At first, it looks like normal post-surgical recovery, a little fatigue, some forgetfulness, mild confusion that is brushed off as medication effects, but then the changes become harder to ignore. He becomes disoriented in familiar places. He forgets recent conversations. He struggles to follow simple daily routines. One morning, he gets into the car and cannot remember how to reach a place he has visited for years. His family starts noticing that something fundamental feels different. Not just slower, not just tired, but not fully himself. And this is where concern begins to grow. Because while the knee has healed properly, the mind has not returned to its previous baseline. This pattern is what clinicians often associate with postoperative cognitive changes following deeper anesthesia exposure in vulnerable patients. Now, contrast this with another patient, an 8-1-year-old woman with a hip fracture after a fall. Same type of vulnerability due to age, same general category of surgery, but a different anesthetic approach is used. Instead of full general anesthesia, the surgical team uses a spinal anesthesia technique with light sedation. She remains conscious during the procedure, calm and comfortable. She talks with her daughter before surgery begins. She is aware, but not distressed. There is no deep brain shutdown, no full chemical suppression of consciousness. The surgery proceeds smoothly and efficiently. Afterward, something very different happens. She wakes up clear-headed, not confused, not disoriented. Within a short time, she is able to communicate normally, recognize everyone around her, and begin early movement with physiotherapy. Within days, she is mobilizing. Within a short recovery window, she returns home. And most importantly, her cognitive function remains stable. Her personality, memory, and awareness feel intact. Now, what makes these two cases so important is not that one had a perfect outcome and the other didn't. It is that both outcomes were clinically plausible. Both patients were treated appropriately within standard medical frameworks. But the difference in anesthesia strategy led to very different brain responses after surgery. And this is the part that families often struggle to understand. Because surgery is usually judged by one outcome. Did the procedure succeed? But for older adults, there is a second outcome that matters just as much. Did the brain return to its previous baseline? And that outcome is influenced by multiple factors: type of anesthesia, depth of sedation, drug combinations, duration of exposure, and individual vulnerability based on age and cognitive reserve. This is why modern anesthesiology is increasingly focused on individualized planning rather than one-size-fits-all protocols. Because older adults are not just smaller versions of younger patients. They respond differently at a biological level. Their nervous system is more sensitive, their recovery pathways are slower, and their margin for neurological stress is narrower, which is why techniques that minimize deep brain suppression are gaining more importance worldwide. But even with all this knowledge, one reality still remains. These decisions are not always made automatically in favor of brain protective strategies. They are influenced by communication, by awareness, by whether the patient or family brings up the concern in the first place. And that leads us to the final and most important part of this entire discussion: how to take what you now know and turn it into action before surgery happens. Because knowledge alone does not change outcomes. Question du, advocacy does, and timing does. At this stage, the most important takeaway is simple. You are not powerless in this process. Before any surgery, especially for patients over 70, the anesthesia plan is just as important as the surgical plan itself. It directly influences how the brain responds during recovery, not just how the body heals. The key is communication before the procedure begins. Instead of assuming one standard approach will be used, ask directly and clearly, is general anesthesia necessary for my procedure, or can a regional technique be used to reduce cognitive risk? Then follow with a second question. If general anesthesia is required, what steps will be taken to protect my brain during the operation? These questions shift the conversation from routine to individualized care. They open the door to options like nerve blocks, spinal anesthesia, epidurals, or light sedation when appropriate. Most importantly, they ensure your cognitive health is part of the decision, not an afterthought. Surgery is meant to restore quality of life. That includes your physical function and your mental clarity. If this information helped you, share it with someone who may be facing surgery soon. And always remember, informed questions lead to safer decisions and better outcomes.